Warm welcome to today's talk, Tuesday the 21st of September. Now, I get a lot of messages challenging me to give evidence for the efficacy of mask wearing. So we're going to look at some research on that. But first of all, I want to talk about yesterday's announcement from Pfizer on vaccinating younger children. Now, this is the press release here. Now, this is a press release rather than a scientific paper, but it does give scientific data. And as we see, this is talking about vaccines for 5 to 11-year-old children. Now, here's the full, basically what is basically a press release. But scientific information is given in it. That's why I want to give it to you now. This will, of course, have to go to become a proper paper. It will have to be submitted to the authorising authorities in various countries, and it will have to be peer reviewed. So we're not at that stage yet. But this is the latest that we have. It's a press release, basically. So this is direct quote from that release. 5 to 11 years of age, the vaccine was safe, well tolerated, and showed a robust neutralising antibody response. And they do give data that says it shows a robust neutralising antibody response, which of course is good. They say there the vaccine was safe. Now, I don't like talking in these terms. I mean, to say something is safe is like an absolute term. You know, it's like saying this is safe. Well, no drug is completely safe. Nothing is completely safe. You know, I would prefer terms like the overwhelming majority of patients didn't suffer any significant adverse effects, rather than saying it's safe. So, you know, a bit uncomfortable when people use such absolute language. It's not the way I would choose to speak, but nevertheless, it's a direct quote in italics, so that's what they've said. Company plans to submit these data to the FDA, European Medicines Agency, and other regulatory agencies around the world, including Australia, of course, where we know they're actively looking at this at the moment. So this is not going to be tomorrow. So this press release was yesterday. It was released on the 20th of September. Today's only the 21st. I very much doubt we'll hear from the FDA this month on this. It's going to be well into next month, and the same with the British and European regulatory authorities. They're going to take them a long time to review this data thoroughly, because that's what they do. So I would imagine we're probably talking about 4-5 weeks' time, possibly even more, not the next few days, for the thinking on this. Right, results in children under 5 years of age are expected soon, later this year. So they're actually even looking at younger age groups at the moment. So that will be the next age group to look at will be 2 to 5s. Now, this particular study, 5 to 11-year-olds. So they had 4,500 5 to 11-year-olds. They were recruited in, I think it was about 80 or 90 centres, 80 centres, I think, quite a lot of centres anyway. Finland, Poland, Spain, and the United States. Now, this is always good. To have multi-centre studies is always good because, of course, there could be local confounding factors in any one area. So this data is coming from a wide spectrum of children. 2 doses, 21 days apart. Now, the dose they're giving here is 10 micrograms mu. So that's 10 micrograms there. So that's 10. I would write that mcg, micrograms, and a microgram, of course, being 1,000th of a milligram, and a milligram being 1,000th of a gram. So anyway, they're giving 10 micrograms to the children, not the normal 30 microgram dose. So they're giving a third of the normal dose. Now, I do like this because the antibody response was basically comparable. I don't think it was statistically significantly different, actually. They don't say that, but it looked very close. So I always like to give the smallest dose of a drug that I can possibly get away with for the maximum effect. So I like this just as a general principle. Give as low a dose as you can for the effect that you're getting. And they found similar results to the ones that received 30 micrograms in the 15 to 25-year-old age group. So in other words, 10 micrograms in the 5 to 17s gave a very similar response, almost the same really, to 30 milligrams in the 15 to 25-year-old age group. And this is classified as a phase 2-3 clinical trial. But it looks like the data is the data that the authorising bodies are going to get to make their mind up on. Now, of course, what everyone is concerned about here is the risk of side effects. So these were reported, side effects reported with the vaccine included. A severe allergic reaction would usually come within a few minutes to 1 hour. There can be a severe allergic reaction, typically nearer the start of the hour. This is typically within a minute or two rather than 30 or 40 minutes. This is why we're often told to hang around for 15 minutes after we get vaccinated in any medical situation, not just for COVID vaccines. But this is not unique to Pfizer-BioNTech vaccine or any other vaccine. All drugs have some risk of allergies, pretty well. I've never heard of allergic reactions to steroids, but ibuprofen, for example, allergic reactions are really quite common, relatively common. So this is nothing unique and nothing surprising. So yes, they admit there's a risk of severe allergic reactions. Now, these severe allergic reactions, what happens is there's mass release of a substance called histamine from mast cells throughout the body. And this histamine actually causes constriction of the bronchial passages and dilation of the blood vessels. So you get this combination of low blood pressure from dilation of the blood vessels, sometimes with difficulty breathing from the constricting of the bronchial passages. But fortunately, everyone knows about this, and there's always, when any time vaccines are given, there's a drug that's readily available called epinephrine in the United States or adrenaline in the United Kingdom. And adrenaline does the opposite to histamine. So adrenaline is a bronchodilator and a vasoconstrictor. So as long as there's medical attention there, this actually doesn't concern me massively. There are very occasional tragedies from these so-called anaphylactic reactions, but they're very rare. And all healthcare providers know to look out for these and know how to manage them. If they don't know how to manage these reactions, they should not be giving the vaccine in the first place. That is for sure. So difficulty breathing, swelling of the face, nose, fast heartbeat, bad rash all over the body, often a red, itchy, usually very itchy rash, dizziness, weakness, sneezing. So they're the features of allergic reactions. Not surprising, get that with anything potentially. So nothing to worry about there, out of the ordinary. But this one is the concern really, and I've had so many emails from parents about this. Myocarditis and pericarditis have occurred in some people who have had received the vaccine. Now, that is from the press release, that is now a fact that Pfizer are accepting. And we have to have a very high index of suspicion for these. Now, because the heart is involved, anytime the heart is involved, I always advise patients to rest, basically, until the cardiologist says don't rest. So if a patient comes in with chest pain, they would automatically be rested until they were reviewed by the cardiologist, who might give different advice, of course. So basically, you want to rest after these things. So I noticed, I was talking to some people in Australia, and actually China, interestingly, and after vaccine they're saying don't take part in athletic activities for a few days after the vaccine. Now, this is not, as far as I understand it, the advice being given out in other countries, but I think to have the vaccine and then within the next day or two go and run a half marathon or something probably would not be a good idea. Just give it a few days, just skip on the training for a few days. Now, if you've got a very high physical demand job, of course, if you're a lumberjack or something, that could be difficult. I understand that. But as a general principle, personally, I try to avoid vigorous exercise for a few days after my vaccine. That was what I did. So in most people, the symptoms began within a few days following receipt of the second dose of the vaccine. So most of the time, the symptoms of the heart inflammation, a few days after the second vaccine. This is why some people are worried about the third dose, because it seems to be subsequent doses that are more likely to cause a reaction. Data on the third dose we don't have. Of course, the press release did say the chances of having this reaction is very low, which it is. But they did point out the features can be chest pain, shortness of breath, and feeling of having a fast beating, fluttering or pounding heart. We often just call this palpitations, an awareness of the heartbeat. Could be a sign of pericarditis or myocarditis. So they're the things to look out for. And of course, it goes without saying, but I'll say it again. The press release says that any of these features, any time really, but especially after vaccination, take immediate local medical advice. So they do give a few other side effects. I'm just going to show you some of those here, possible side effects from the Pfizer vaccine in this age group. Injection site pain, not surprising, tenderness, headache, muscle pain, chills, joint pain, fever, injection site swelling, injection site redness, nausea, feeling unwell, swollen lymph nodes, which is called lymphadenopathy, diarrhea there with the American spelling, vomiting, arm pain. And they do also say there's no information on the use of the vaccine with other vaccines. Now, of course, what they'd have to work out is if this vaccine is going to be given to the 5 to 12-year-old group, how are we going to the 5 to 11-year-old group? Sorry, how is it going to fit in with other vaccines? And they haven't done that yet. Now, this sounds like a pretty horrendous list of side effects, but here's a medicine I'm taking myself. Take a few of these a week. It's called lansoprazole. So lansoprazole. So whenever you get some meds in a box, you'll get this sheet here with all the blurb on it. And I'm just going to show you. So I take lansoprazole. It's good for heartburn and things like that. And I never, as far as I know, I never get any side effects at all. But because thousands of people around the world, millions of people around the world have been given this drug, they collect a lot of side effects. So you tend to end up with quite a few on the list. So here we have possible side effects. Can we see that? Such a long, like a scroll. Possible side effects. And the possible side effects from this drug, angioedema, severe hypersensitivity reactions, including anaphylaxis, very severe skin reactions, common side effects may occur in up to 10 people, headache, dizziness, blah, blah, blah. You know, there's just, you end up with huge numbers of potential side effects to this commonly used medication. So there are common side effects there. Then there's uncommon side effects and rare side effects and very rare side effects. And you know, so in other words, what I'm saying is, you know, side effects from medicines are basically they're inevitable. All medicines have some side effects, but I've never had any of those, so that's fine. So there you go. We're waiting for the authorising bodies now. Now we can assume that the authorising bodies around the world will be given full documentation, full access to manufacturing, and decisions will happen, but not quickly. So that's on that. Now this story caught my attention here. This is the Centre for Disease. It's the FDA, Food and Drug Administration, here communicating via Twitter. So the issue here is that people have been taking ivermectin, apparently, mostly in the United States, that was designed for horses, an equine preparation. So FDA usually put a picture of a horse on here so we can be clear about that. You can tell horses they've got the long sort of face like that, as opposed to this human who is presumably the vet. There we have two other humans as well. So you're not a horse, you're not a cow. Seriously, you'll stop it. So this is the FDA saying why you should not use ivermectin to treat or prevent COVID-19. Using the drug ivermectin to treat COVID-19 can be dangerous and even lethal. The FDA has not approved the drug for that purpose. The issue here, of course, is that animal preparations could be different to human preparations, and horses weigh a lot more than us usually, so the doses would be different. So, of course, the FDA announcement here is absolutely correct. We should not be taking veterinary preparations. Now, I've got more to say about this in the next video, but we'll leave that there for now. But of course, if anyone rang up their doctor and said, "Doctor, should I be using veterinary preparations to take as a human being?" I'm sure every doctor in the world would say, no, you should not be taking veterinary preparations because you're a human being. You should be taking human preparations. So the FDA is quite correct. And if you're interested in that, I just thought it was a good thing to talk about. That there's the references there. FDA actually, it's like anything else on this. Once you get onto it, you tend to be there for ages, because the FDA publish a lot of stuff on Twitter, which is pretty interesting actually. Right, now let's get on to today's research paper, which is here. Peer-reviewed, published, infectiousness of SARS coronavirus 2 in exhaled aerosols and the efficacy of masks during early mild infection. So full paper there, available in PDF, available for public domain use, which is great. Quite an accessible paper, it has to be said. For a scientific journal, I found it really quite accessible, but I'm going to give you the highlights of it now. Now, epidemiology implicates airborne transmission, aerosol infectiousness. So these go out in aerosol. So the difference here, as I think about it, is you know, if someone's got one of these aerosols and they spray it on one side of the room, then after a few minutes you can smell it on the other side of the room, like perfumes or deodorants or something. I hate them myself, but don't like aerosols at all. But you can smell it. It sort of goes through the room as an aerosolization, and that's because basically aerosolized particles are very small, and they can hang in the air for a period of time, as we know, and they can be associated with water vapor in the air as well. So when we breathe out, we are breathing out some aerosolized, very small particles, but we're also breathing out bigger particles as well. The bigger particles of water that we breathe out tend to fall to the ground much quicker. The ones as an aerosol can hang around, and we've seen evidence for up to 3 hours that these can hang around in the air. But anyway, let's look at this particular study. Confirmed cases gave, so these people gave in this study, they gave blood, saliva, mid-turbinate samples. So basically the mid-turbinate is it's like a deep nasal swab. It's not at the front of the nose, it's not right back at the nasopharynx, it's kind of halfway back into the nasal cavity. Because the thing about the nasal cavity is you think it goes up, but it doesn't, it goes pretty well straight back. So fairly deep nasal swabs is what they were doing. 30-minute breath samples while vocalising with and without masks, and they had a clever machine there that they could breathe in and out of that actually quantified the number of viruses. So basically they could count the number of, or the amount of viral DNA that was being, viral RNA, sorry, it's an RNA virus. They could count the amount of RNA that was given out to quantify the viral load. Some people had one visit, some had 2 visits 2 days apart to give this information and do these exercises, vocalizing while breathing with and without, well, obviously breathing, but vocalizing with and without masks. So they quantified and sequenced viral RNA, and they also cultured the virus, which was pleased to see that actually. So what you have to do, these viruses aren't that easy to culture. So what you do is you actually collect a sample with the live virus in it. And then normally to culture bacteria, you just do it in a Petri dish. I mean, you can grow fungus, for example, on the top of a jar of jam. You just leave the lid off. But to cultivate viruses is more difficult because they are obligate intracellular parasites. So you have to have a human cell culture to actually grow these in. And then the virus will multiply and then you can reculture it. And this is good because this is how we know that the disease is infectious. It meets what we call Koch's postulates, after Robert Koch, who put forward these postulates. So basically it's saying that the active virus must be identified in all lesions of the case, that you must be able to culture this virus and identify the virus again after you've cultured it, and ideally reinfect someone else with the same virus that you have cultured. Koch originally did it with bacteria, but it applies to viruses as well. So good to see that. It's just rigorous, thorough science. So let's look at the results. Now they recruited 49 people. Okay, it's a small study, but it was a very thorough study. And they were seronegative. In other words, they had not had the disease before. So they had the antigen, but they didn't have the antibody, so they were seronegative. Mean days post onset of symptoms, 3.8 days plus or minus a couple of days, 2.1 days. And this was the long term, fairly long term. This was done from May 2020 all the way through to April 2021. And of course, this is what they were able to analyse then was the variant around at that time, which was largely the alpha variant. So this could be slightly different for the different variants. So they detected SARS coronavirus 2 RNA in the alpha variant type RNA. But this alpha variant RNA was detected in 45% of the aerosolized particles that the infected people breathed out. So there was aerosolized particles in 45 people, and they defined aerosolized particles as less than 5 micrometers in diameter. But they also detected SARS coronavirus 2 RNA of the alpha variant type in 31% of coarse water droplets. They're still calling them aerosols, but these are the larger droplets here. So there was 45% of the virus in the 45% of these had the alpha variant in the smaller ones, and only 31% in the larger ones. But the trouble is, these are the ones that hang in the air for longer. It's the ones that hang in the air for longer that are potentially more of a problem So these did have, a lot of these did have SARS coronavirus 2 alpha variant RNA in them. And the fomite is a vector is anything that's alive that's transmitting disease, and a fomite is anything that's not alive that transmits disease. And what they were actually testing here was the people's mobile phones, which of course you're talking on really quite closely. And 65% of those tested positive for the virus as well. So clear evidence here for the aerosolized spread of the virus. You know, I just remember early on in this pandemic, Dr. Tedros was saying in a WHO press conference, this is an airborne virus. And I saw Dr. Ryan sort of nudge him and pass him a note. And when he got the chance, Dr. Tedros says, well, we don't mean airborne as in paratroopers. So Dr. Ryan obviously wanted him to draw back on that. But of course, that's exactly what it is. This is airborne as in paratroopers. It can hang in the air for a long period of time, which of course is why ventilation is so important, to keep your air fresh and open your windows. Now, what about wearing masks? So masks reduce viral RNA by 48% in the fine aerosols and 77% in the coarse aerosols. So we see definite reduction in viral load wearing masks. It's what we've always said. Well, it's not what I've always said. I started saying this on the 17th of March 2020. That's how long we've been saying this. Cloth and surgical masks were not significantly different, interestingly. So that's interesting. And what we've always said is that the mask is just physically, a good fitting mask of course is better, but you know, a mask that physically disrupts the momentum of the air is going to have a big difference. Now, of course, this is the alpha variant, so how this works out for the delta variant, I would expect it to be similar, but we don't know because the science only tells us what the science tells us. But I would expect it to be the same for the delta variant, even though the viral load may well be significantly higher. So the alpha variant compared with earlier variants, some studies showed a 43% increase in fine aerosolized viral RNA, but it's actually probably nearer the 18. There remained a significant 18-fold increase adjusted for viral RNA in saliva swabs and other potential confounders. So basically what they're saying is that the exhaled aerosols in people with alpha variant, you know, the so-called UK Kent variant, that contains 18 times more virus than the original strain. And we believe that the Delta variant is containing even more virus than this. So how many times fold that is, we don't know. That's not what this paper does. But we do believe it's significantly higher with the Delta variant. So two things there. First of all, the efficacy of masks in reducing viral load. This is firm data for that. And the second conclusion that they make, and I'll just give you what they've said about it, it's evolving, the virus is evolving towards more efficient aerosol generation. So this is one of the ways that the virus is evolving. Now there'll be a limit to that, we would assume, but the Delta variant is even more transmissible than the Alpha variant. Loose-fitting masks provide significant but only modest source of control. Continued layered controls, like layered masks, and tight-fitting masks and respirators will be necessary to prevent the transmission of the virus, and more so with the Delta variant. So again, consistent with what we've been saying for quite a long time on this channel, but it is good to get the science that that just confirms that. So I was reminded of some of the reliable statements we used to use last year. Follow the evidence wherever it leads. We need to move from reactivity to proactivity. We've got to be thinking ahead more. Hands, face, space, and of course, ventilate. Masks are critical, not political. Our health depends on everyone else. 2 meters distance determines our existence. So the reliable sayings are still reliable. Always reminds me of that Bob Dylan clip when I do that, but there you go. Right, that's us for today. I'm working on, today and yesterday I've actually been looking at the reduction in cases in India, which is dramatic, and there's a lot to learn from that. So that's what I plan to do on the next video, but thank you for watching this one.